Good morning, everyone. This morning we will have two seminars, and the first one will begin from 9:30. So the first seminar will be given by Dr. Hugo Escobar, and Dr. Hugo Escobar is the researcher at Department of Oncology, Haematology and Palliative Care at Rostock University from Germany. And his topic today will be academic institutions for research and international exchange and actual results of multilocal research on SARS-CoV-2 vaccinations. Dr. Hugo, please.
Well, good morning, and thanks for the nice introduction. It's really a pleasure to be here, as it is especially the second time for me in person. This honestly has a couple of more times been here. And if you are invited twice, it's always good. So, as mentioned, I'm a researcher, a wet lab researcher, and I'm totally aware that wet lab research in Hong Kong is very, very strong. But as a key part of our exchange is the intellectual and cultural exchange, I will be giving like an introduction of how universities are structured and differences that we have compared to Hong Kong and what we have as external research institutions, which are really, really mighty in Germany and big part of our research culture. So, but before we get into this, a couple of words to Germany. We are located somewhere around here. Yeah? And these maps are, everybody knows them, but I think much more interesting is watching the world by night. And so, because everywhere where light is, this means that there's life. And we can see that we have, like in Europe, there's like a spot, we are somewhere there, it's the United States, you guys are here around. And this means that there is a lot of things happening. So if we take a closer look to Europe, we got this that we see Italy around here nicely, and this is like Belgium, part of the Netherlands. And it's not that there are so much people, but these guys illuminate the highways in the night. That's why they have so much light. Right? But we are currently located around here. Yes. So this is Germany, and then we have Berlin, Hamburg, this is Bremen, and here is Rostock. And as you see, we are in a special place of Germany because the population density is not as high as it is in other parts, which means that for medical care, we have different challenges compared to high populated areas that we have here in Hong Kong, or we have in this coal mining areas and industry areas of middle of South Germany. So Germany is a really small country. Right? We can do it driving in one day. Right? So from north to south, roughly 1,000 kilometers. Highways are off speed, so you can drive as fast as you can. In 10 hours you can do it. We have a population of 83 million people, and the density is 2.33 on average. In the state where we are, it's much less. We have 73 or 74 or something. And I checked how the density in Hong Kong is, and you guys are 6,800 people per square meter. So you see, it's totally different in how we have to take care for medical treatment, as we don't see so much patients in time, and we have to be aware how to reach patients which are located in rural areas where maybe there's kilometers of line. Okay. So we have 16 federal states, and this is a nice thing, and it's always a nightmare, because all these federal states have also their own laws. And then there is a central government which gives like shape and structure to it, but the independent states have a lot of own decision potential, and this sometimes is complicated in for medical care, especially complicated as the insurance companies negotiate with the states what they are going to do. And so In general, everything is covered, but there are different on the single space. So, okay, measurable four-point SSS is around here, and we are from Rostock University. And Rostock, it's for German or European standards, it's an older city, but it's not very old city, but it's an old city. Yeah, so we were founded in 1218. And then in North Germany there was something called the Hanseatic League, which also spins the South Baltic area, which was a commercial unity where people exchanged a lot. So we are a typical port city like Hong Kong. So we are used to have exchange with other countries in other cities. This is how Rostock looks today. And some people, I'm not from Rostock, but some people call it the Pearl of the North. But I think everybody from every city in the South Baltic area really says this. So, okay, good. So if we check for Germany, and if you guys have a chance to go to Germany, there are a lot of things that people think which are typical German, and there are a lot of things that might be worth trying. Yeah, so if you have the chance to go to Germany, take a look at this. So one thing that Germany is known for, which maybe is not cars and technology, is that we have a lot of different food. So especially in bread. And you really find it from very, very hard, dark breads to very soft bread, as you guys have over here. If you have the chance to go over there, it's nice, strong. And Germany, and especially Belgium, have tons of beer. Really, really love different brands. And this is historically driven as the old monasteries were the ones that were allowed to earn money by doing beer. So we have tons of orders. And what's typical German also is sausages. Yeah? So for the people which are not from Germany, or maybe you guys also don't know. Yeah? So what do you think? How many different types of sausages we have in Germany? 500. So then we have 500 to 500 and 500 plus. Who thinks we have more than 500 different types of sausages? Well, there's 1, 2, yeah, the Germans are best. Okay, yeah, it is. You know, we have like more than 1,500 different. And this is really, you can spend days on it, yeah, and weeks. So if you have the chance to go there, taste as many as you can. I like a lot, I dislike a lot. There's nothing you can do wrong. And the last thing that I want to say, which is something where we have to work on, is our sports. Yeah? So Germany is like soccer. This is the top sport that we have, and this is how the world sees German soccer. And also how a lot of Germans see it, but reality sometimes is different, and we know this from research especially. So the actual thing is this. Yeah? We have not been qualifying for a lot of things. Yeah? So we have a lot of room to improve in our sports. Okay, so but back to our topic, which is actually the academic institutions and how do we perform structural research. Obviously, we have universities like ours. And then there's the general universities with tons of faculties in, and then there are specialized universities which are independent and have their own rights, and they are not really linked to another university. Like medical schools in Hanover, for example, is independent. We have a couple of veterinary schools which are complete universities independent, and they do not belong to a major university. But we have this, and this I think is the more interesting part, and I will be going into this in detail, which is independent research structures which are not universities but perform strong research. And these are very influential in Germany, and if you are checking how a university is developing, it is always developing with these research structures if these guys are going for research. So, universities, as you guys also have, we check European universities, we see that we start around 1,000 years after Christ in Italy. I think the oldest documented university, which just means that there's no written thing of earlier. So. But I think the oldest documented university is in Morocco in Fez, which was like 800 something. And if we check, if we check Germany, then we see that roughly around 1300 something German universities starts to rise as in the years. So Rostock University was founded in 1419, so a couple of years ago we had like 800-year celebration of Rostock as a city and 600-year celebration of the university. And Rostock is a small city, that's 250,000 people. Yeah? So I think it's nothing compared to maybe one of your small areas. Yeah? But we have a close interaction between the government and the university. And this is another German thing which we have, as this is German universities, they are all taken by the government. So actually we have a couple of private universities, but no one works. It's because they have a bad reputation that you are paying for your years. So it's all funded by the state. And so there is in total, from last year, there's roughly 100 universities that we have in Germany in this small area. So if we go for Rostock U, as I told before, it is funded 1419, and it is, I think, the oldest one in the complete South Baltic area, which started with medicine as an old faculty. Usually it was like life science or mathematics, philosophy, religion, but our alma mater started with 3 faculties, so with arts, with law, and with medicine. And in academic profiling, there is different things that University of Rostock is following, which is life, light, and matter, which is based into physics. Obviously, as we are located on the sea, maritime systems, maritime ecosystems. Then there's aging and society, which also includes long-term cancer research, and knowledge about cancer, culture and translation. And this is typical for a port in a very old city, as we are highly interested in an international university. If we check the medical faculty has a profiling process which identifies 3 parts where we are focusing on. So one is oncology, this is obvious as a lot of people. The second part is neurology, neurologic disease, and the third part is biomaterials, which goes in the direction of suspense and the movement. So if we go for oncology, Rostock U and all other universities, they choose a focus area. And our focus area in oncology is called burden of cancer. So the research and also the development of research in clinical care goes below this thing of burden of cancer, which means that if we take a look at cancer, we try to address it in a holistic way. This is actually what everybody does. Yeah? But if we check what happens to a patient or a person which is affected by cancer, it's not only him. And so it will be affecting also the family, maybe the income, it will be affecting the people he's related, his working groups, everything. So actually there's much more to take care of than just the patient with all his needs and his skills. And this is what burden of cancer, in Rostock does. And this is not what every university does. So there are bigger medical faculties than we have in Rostock. And there's also in other parts of Germany stronger research. But we are focusing on this holistic aspect to include everything. And I think this fits very, very nicely to traditional Chinese medicine, as the spirit is not identical with it. And obviously in Germany, traditional Chinese medicine is not as focused as it is here. So we have people like Hans Lampe who are introducing it and has nice results, but most clinics in Germany doesn't have a structured way to introduce TCM in our care. But we have physical activity. And this is what is in part what we call, for example, oncology training therapy, which is done in our clinic, for example, with Sabine. She's actually a sports scientist. She's not a medic, she's a sports scientist. And so what these guys do is that they start working with the patients even before they go into chemo. Which is maybe we would call it strengthening the chi, maybe with Tai Chi or something. They do it with sports. And they try to do sports with these guys, and then they go with these sports through the medical education as the patient is in conditions to do it, and then also they take the rehab. So this is something typical for Rostock. And oncologic training therapy, I think there are 2 spots in Germany who does it, which is Cologne and Rostock is doing it. It is structured. So, and then we have this, obviously in Rostock, but we have also study groups like the OSHO, this is the Ost-German Society of Study Groups, and we have been rolling out a couple of these-oriented integrated studies to East Germany. So Rostock is the main point. Okay, I was not really aware if some students would be here, but even if you are advanced and you are in relationship with somebody from Germany, from a university, it's good to know how we do structure our doctoral degrees. And this is very, very different to the United States, to also to South America. So in Germany, we don't have traditional structured PhD programs. There is bigger universities that does this. So like the 4-year program, we have the 2 courses, like in North and United States. But in Germany, this is not the traditional program. So we offer doctoral degrees depending on the faculties. And this is born by the fact that we have a lot of old universities with high traditions and crowds and etc. And they said, okay, we will be the one giving a doctor title degree for this and this. And this results in a slight case. So this is all the types of doctoral degrees you can do in Germany. So if you see that somebody is a doctor, you can do doctor in whatever. So and it not always has to be a medical examination or engineering or medicine. So, and okay, this can be a challenge to know that there's a lot of difference, but there's also a lot of difference in the time that you will be needing to get this degree. So for example, a medical doctorate, if it's not a PhD, a medical doctorate can be a year working. Life science, in this case, nature science and biology, chemistry is up to 4 years. And you won't see the difference in the doctorate only in the letters of our doctorates. So this is good to know because sometimes you will be meeting different expectations. And the major difference is not the titles and the time, it's the relationship you are having to your mentor. And in Germany, the traditional way to do it is a mentor-disciple relationship, where one professor will have 1 or 2 PhD students, or he has lecturers or senior professors, assistant professors like me, who will be having also PhD students. But usually, it's the direct relationship between the professor and the student. And the professor is the one also who decides when he is they're sure to give the examination. So there's no structured program saying, okay, I have to do this, and this, and then I have half a year to answer this. This will not be happening usually. Okay. Good. So knowing this, we go to where can we do this. And the German research institutions, especially the universities, are distributed in. So as I told before, we have roughly 100 institutions which are allowed to call themselves universities. But if we take together all academic working centers, which are below universities and external institutions, we are roughly dealing with 25,000. So, and this makes it very, very heterogeneous on how a project can be composed. And if you are just focusing in cooperation on universities, you maybe are missing a large part of very strong institutions. However, as we know that this is a problem, there is databases as a gathered database where all these institutions are within. So if there is a project idea or cooperation inspiration, it would be wise to check obviously the universities, but also the other institutions. One will be giving you an easy example of this is, for example, call from the European Community for Funding, where we have now just a project within, and the European Community says, okay, it's for Europe, but we are limited in this Baltic program only to several states. We have like Denmark and Sweden, and Poland, and Slovenia, and just this part of Germany. So just this one. So if you have to find partners there's two major universities, which is Rostock. But there's a lot of other research institutions that can be joining the approaches. And that's how we do it. Okay. But the concept of universities is something that's totally familiar to Hong and to all other parts of the world, obviously. And in Germany we have four very, very big players who are independent of universities. And these, like I like to call them the Big Four, which is the Max-Planck-Gesellschaft, Helmholtz institutions, Leibniz-Gemeinschaft, and Fraunhofer. And the major difference in these is that these guys do research on very high level. They do absolutely no teaching. They have no students, they have no teaching. They maybe take master people or bachelor people to do a degree and for making their doctoral thesis, but usually these guys will be hired in postdocs. And I will be giving you only a short glance into it, so that you maybe have a feeling about these institutions. And actually, it's not one institution. For example, Max Planck was funded after the war. So even in our perspective, it's a young thing. We have like 70 years of it. And Max Planck has 85 different institutes and academic institutions, which are non-university related. These guys have a yearly budget of nearly 2 billion euros, which is a lot of money for Germany. So to be independent from as not being a university, being an independent institution, 2 billion euros is a lot. And so the system in this, as if Max Planck takes different areas that they are interested in, like for example, vaccination studies or 3D AI development, and they found an institution. And they use also the federal government to finance this, but they do it on their own perspective. It's their own initiative. And if we check the number, I apologize that this is in German, but this is the number of papers that they raise in our report. And the sightings that these guys give, for example, in physics, this is materials, this is astroscience, biology, biochemistry. You see, it's really strong research institutions. And the Max Planck-Gesellschaft is surely one of the major players which has definitely to be taken into account if we are going to do this. In Mecklenburg-Vorpommern, we have two Max-Planck Institute, and one is for demographics, and this is the one where our clinic is working with. So when we do the studies going for evaluation of demographic development in terms of disease, and we work with Professor Rau from Max-Planck Gesellschaft, and he is easily the strongest around also in the clinic. This is very important. So the second one, which I would like to present, is the Helmholtz Institution. And Helmholtz institutions they don't have so many institutions as not. They are really, really young. So these guys are like 30 years old. And it's political and intellectual think tank politics which are taken there together, and they have like a couple of Nobel Prizes and a yearly budget of nearly 6 billion. For 18 institutions, this is a lot of money. And if they do it similar like Max Planck, they have different topics where they are focusing on. And for example, we are working with the Max Delbrück Zentrum, which is also a center interested in nutrition, Chinese medicine, working mechanisms, and have all research projects where we are directly cooperating with the Helmholtz institutions. So this for an international cooperation with German groups can be also very, very strong. So then there's the Leibniz-Gemeinschaft. And the Leibniz-Gemeinschaft is named after a natural scientist called Leibniz, who was located a long time in Hannover. And Leibniz is also, so 1990, so 30 years, compared to the 1,000-year-old universities with nothing. But in despite of this, Leibniz, like Olympians, have nearly 100 different institutions, maybe 20,000 people employed as researchers, and a yearly budget of $2 billion, so which is a couple of dollars. If we check Mecklenburg-Vorpommern, we have 4 of these institutions, and this one here, the LICA, Leibniz Institute for Catalysis. These are chemists guys. And I think this is one of the worldwide strongest, as I understand, chemistry. As I understand it, it must be something very special, so they are very good. And we have been performing a couple of research projects with this Leibniz Institute for Catalysis, nearly in the same manner which we are working our TCM projects, which is like having a chemical compound. In this time it was like a candidate for a new drug. And then we do the experimental verification if the drug works. Starting from different in vitro body systems, as you guys obviously do, and also the same things here. But as this institute is located directly in Rostock, it's like, I think, 1.5 kilometers away from mine. So, and this makes things very easy, as you can make like meetings, student exchange, very, very easy. But remember that these guys usually don't do students, you can send one to watch it. Okay, so Leibniz Institutes, very strong. And last but not least is the Fraunhofer Gesellschaft. And I put it these guys as the last one because in one way they are special, they are not really interested in academic publishing. So Fraunhofer does tons of research, but these guys are interested in making money out of the research and patent things. So for us it's complicated because if we have a research project, as every researcher in the world, we are forced to publish. Fraunhofer says no, we can't publish because we have patent. And For elderly people like me, this is okay. Yeah? But if I have like a student who does English degrees, he will be needing practice. So we have projects with Fraunhofer, for example, in digitalization. This is an institute which is directly located in Rostock, and they do like graphics and modeling of different mathematical things. And what have we been doing? And this is also part of our comprehensive burden of cancer project, is that we developed a project with them to address stress and distress, but not in patients. We address them in caregivers, especially nurses. And we check, so in the field of palliative medicine, where Ursula is the specialist, so, how the situation of palliative care does an extra stress on nurses. So, as I said, it's the digitalization thing. And we have palliative care as a challenge, but if we look, so how many patients have to be taken care with one nursing employee, we have a very bad relationship between them. Right? So if we compare us with other countries, then we have to take care of much more people having this one caregiver. And this is an extra stress. So, and it can drive people into burnouts, which we don't want. So the idea of this project was having a device. In this case, it was the smartwatch, not a real smartwatch, something a little bit more advanced. Yeah? But when I asked them to design my Apple Watch, they start laughing. And it takes a lot of biometers, which is oxygen resistance, whatever magic they can do. And then we had this, this measuring of biodata by the watch, plus structured interviews, like asking the people, do you feel stressed, which situation is stressful? And then we developed an algorithm which would be identifying the palliative ward in our clinic where we did this trial, and then linking the data. So it is like a combination of bioparameters, feeling question, and also caregiving, and seeing how we introduce this into a project of the university and the Fraunhofer Institute. What that these guys were interested in, how can we record the parameters, how can we artificial intelligence in reading out if we can see something in these parameters, and how this correlates to the stress that these guys think that they are feeling. And we identified a lot of things where they are already distressed and they think that they are. It's currently ongoing, so there's up to now there's no real paper on it, but we have been showing a couple of results of these things in different conferences, and I think we will be hopefully having a paper this year or early next year once we have taken together. Okay, so this is the academic institutions, and especially the non-academic or research-strong institutions, which should be taken care of if we are looking for Germany. If we are looking for Germany for research. And then there's a second interesting or very, very important part, which is obviously the funding. So where do we get the money for funding, and which possibilities do we have? And if we check the major funding things, then there is three big structures, which is called clusters of excellence, then collaboratory research centers, and the comprehensive cancer centers. So, and as you remember, Germany is a small country, so we are really small. So research funding is obviously in large parts done by the government, also by industries and non-governmental institutions, but the major player is the government. And this is a so-called German Research Foundation, or as we call it in German, Deutsche Forschungsgemeinschaft. So what do these guys do? They fund and push research in all areas. And they take care of the complete academic landscape that we have in Germany, which means universities, but there's also ways for Max Planck or Fraunhofer together with the university to get some funding. So it has like several branches, science and humanities, and besides the national research funding, these guys have strong impact on establishing and keeping international cooperations. So for things like we are doing now, summer schools, DFG together with the German Academic Research Exchange, which is called the DAAD, can be really, really strong partners and players to develop this. So, as I mentioned before, they encourage international cooperations on different levels. So it starts from undergrads for exchange, goes also to summer schools, but also postdoc researchers, even complete research groups, which can be relocated for time-wise to go where research experience are in industry. So as we check the DFG, there is always like a strong focus on something, but if we take a closer look at how these guys distribute their money, and we know it's good to see. I apologize, this is only available in German. So we have a budget of nearly 4 million euros. And if you remember, this is a governmental research funding institution. Has a similar budget than the independent research house like Max Planck or something. Okay? So this puts it into relationship. And in 2022, they funded roughly 31,000 individual smaller projects. And this is a distribution where in parts the money goes. And the red one here, so the peak is life science. The green here is natural science. This is like philosophies in yellow, and what they call other things. So large part of DFG funding goes into life science. And if we check for the major parts for the research clusters, these are structures which usually are funded for 4 years, and then you have the chance to extend them twice, so a maximum of 12 years, and they will have a budget of nearly 40 million euros for funding time. So 12 to 50 million euros for 12 years. This is what the research cluster has. And as in Germany, we don't go so much for rankings of universities. It's defined by the number of research clusters that these institutions get funded by the German Research Foundation. And this is a map of 2022. So you see that in bigger cities like Munich or here in Berlin, we have tons of research clusters. And the Mecklenburg-Vorpommern, we're working on it. There's a new call, and we hope that we will be having the first excellence cluster this decision in 2024. But research clusters are the ones where the structured German research financing is going for the largest high competitive studies. A little bit more smaller, but not less competitive, is the collaborative research studies. And the difference in this is that the budget of the collaborative research center is around 20 million euros, not 40 million as excellence cluster, it's 20 million euros. It's equally tough to get them. And here we have at Rostock, we have 2 SFBs, and then these usually, the collaborative research centers are a little bit more focused also develop them, they go with graduate schools. So there's funding of SFBs, how we call them, and usually we have kind of graduate schools in the different topics of the research classes. So this is where the governmental money goes. And then the large and the third part is maybe as far as more interesting in this part is the comprehensive cancer service. And in Germany, cancer care is structured as you have, okay, the normal practitioner, there may be a couple of practitioners working together, and then there is something which we call oncologic centers, and on top of it is that we have the comprehensive cancer centers. So in structure and difference, we have the origin-specific centers which are above the average oncologist practitioner. And what they do is they have certified care. So this is like following the guidelines from the German Cancer Society. And you will be knowing if you are treated in one of these centers, the standards will have a different. We have a structured background and backbone. And one above these is that we have the oncologic centers. And usually they cover different entities, so it will be that you have like what we call it oncologic sampling for gastrointestinal cancer, then there's one of West, all these things. And they are certified and they have to go to auditings by the German Cancer Society, which is the Dutch HKUSCM, which does the certification of these research of these oncology centers. This is only patient care. There is no teaching, there is no students. It's patient care. So a middle-sized middle-sized hospital, if it's well organized, it can be handled in oncology center. And above this is the comprehensive cancer centers. And this is usually all which we have below, plus teaching, research, and addressing expertise. So you look the difference, and this is close to what we have in the other aspects. We have the three areas of patient care, research, and teaching, and only if academic centers are able to address these things integrated, like we have here in the office, integrated in one way, then they will have to apply to be evaluated if they classify as oncology as there is different way of funding it, and this is a map of Germany showing the comprehensive cancer centers. Traditionally, there's by the German Cancer Aid there's funding, but there's also alternative fundings. And this would be the map with the distribution of comprehensive cancer centers in Germany. And as you see, our hospital is over here. We have one comprehensive cancer center, but there is large part where there is no comprehensive cancer center nearby. And this is something which can be challenging. It does not mean that there is no oncologic centers. So there's a lot of oncologic centers in between. But if you go, for example, for CAR T-cell therapy or something, then patients will have to move to one of the more advanced academic institutions. So for Rostock, we are organized in the Comprehensive Cancer Center Mecklenburg-Vorpommern. And it is composed of two parts. So it includes Mecklenburg-Vorpommern is our state. It includes us in Rostock, and also the medical facility is a university of Rostock, which is 100K away. It's 100K? So, and this comprehensive cancer center, like in the Vorpommern, is something where we unify those medical academic fields in universities to one structure. And this is not always easy. It's two different universities who will have different professors, different interests. But for the greater good, these guys work together. And we have been developing this for, I think, like 2 years, and took 2 more years to putting them together to get a funding for. So this is how the Comprehensive Cancer Center I mentioned before is structured. So it's structured, advanced medical care, distributed onto two pillars, pilots here. And we have the lower part of cancer with integrative medicine, and in Kreisland has a focus on community medicine. So it's working together hand in hand, and this is how we are trying to develop care for cancer patients in the community. Okay. So switching gears to the academic exchange programs, which is something which is relevant for summer schools like we are trying to establish, or we are establishing here. I think the most important player is the DAAD. So it's called the Deutsche Akademische Auslandsdienst, which really is a German academic exchange service. And these guys work closely with the DFG as well as with the governmental institutions. And the only job of them is to push international cooperations and exchange. This is a major topic that they follow. So, and it is independent of your career stage. And so it can be for early career paths, and it can also be for postdocs, established researchers, professors, and also parts of complete research units where you can apply, for example, saying, okay, we think it is important that we have 4 people working in close relationship with someone, and then you have to apply, and there's a good chance to get it. It's not easy, but there's a good chance to make it. And if your science is sound, then it will work. And I checked for 2021, and I checked for the years earlier. And we have currently, these guys are funding nearly 400 people from Germany and China, and they are funding roughly 2,000 Chinese people to come to Germany. So, and they work together with the CSC, so with the Chinese Research Council. In earlier years before the pandemic, this was nearly 1 to 1. So I checked the numbers for 2017, and then it was like 2,000 something people from Germany in the different parts of China, including Hong Kong. They don't differentiate anymore. Yeah? But this is a new thing. And, actually, they had like 2 offices a couple of years ago. One was based here in Hong Kong, and one was based in Beijing. And Hong Kong was shut down, I think, like 3 years ago or something like this. Somebody saying yes. Okay, so that's good. Awesome. So they don't distinguish it anymore, and as I understand correctly, the paperwork is now have to be done with Beijing, even if it affects me. But if we check what these guys do, they offer scholarship programs in all areas. And this, I think this is very, very interesting, as it is a structured tool to push academic exchange independently if you are a researcher from China, Japan, or your German. You can apply, everybody can apply, but it has to have like a cooperation, international exchange to do it. Okay? And there are tons of structured tools which they offer. I just picked like one or two because it's too much to show them all and it's pointless. So I think the critical thing is to have the information that the VAAD together with the Chinese science and research community, scholarship council, are offering structured programs which can be helping to develop research and especially international applications. And as I told before, it is totally professional now. So there is also a part which addresses directly the institution. So scholarships usually, even if it's researchers, goes to individuals, but they have also projects and tools to have like complete academic institutions going into exchange. And this is something which is highly interesting in my point of view. If we try to develop and enhance things like that, which I think is totally important. And when I remember the first seminar which we had, where we asked also Hong Kong-based students what they were expecting of this, a couple of them said new friendships and knowing the best. And this is exactly what the National Exchange Corporation is structured. So I think, I think that this is a part where we can be developing, and we should be using this toolbox to enhance the things that we have. Okay, good. So, and last but not least, the title said I should be presenting something with COVID vaccinations. And this is what I'm going to do now, and I must be apologizing up front, as this is a project which is from our institution in our clinic, but it's not my clinic. So this is Sebastian Virtual and Hobby, and if somebody records this and they see the record, they will be, you can tell the important things of this. Yeah, so, okay. This is an example of what we have been doing in Haematology in COVID times. And it's a study which has just been published. And so the aim of the study was to identify or to check if there is a difference in the active T-cell populations of cancer patients in response to the different vaccinations. And I'm sure, I don't know how you did the vaccinations in Hong Kong, so it was a different types of vaccinations or only one type? Two types? So messenger RNA and vector-based? The two American trials. Yeah. Okay. So we had like a Germany-based development of vaccinations, and in Germany it was a chaos. Yeah? So I think everywhere in the world it was chaos, but we had a special chaos, as we had in sometimes 4 different vaccinations. And we had like these mRNA-based and also vector-based RNAs, classical ones. And there was a lot of insecurity because there were like strokes and heart attacks reported to vector-based vaccinations. And I think it was like single cases. Yeah? But the population was totally unsecure and people didn't want to have the vaccination, which was vector-based. And this led to a challenge as we had to vaccinate people. had also vaccinations. In the beginning it was tough to get them, but afterwards it was nicely. But then people don't want to be vaccinated. And it was such a challenge that in the academic medical institutions we had at one point people were saying, if you are not vaccinated, you will not be allowed to work in this institution. So this is things that news sometimes forget. But it was not easy. So, but what did these guys do? The question was, or one of the questions was, is there a difference in quality in your immune response if you get vaccinated by A or B, or C or D? And the nice, everybody wants to have vaccination with the mRNA-based vaccination. And what they did was that they took a look at different patients, which lymphoid malignancies and myeloid malignancies, and analyzed in a structured study with controls. So this will be the patient cohort. You see that here roughly we have like healthy controls, our lymphoid patients, and myeloid patients. And they analyzed which kind of vaccinations did these guys get. And if they were infected with COVID before cancer or if they didn't. So the question was, if we have cancer and we have therapy, for example, and compromised immune system, will there be a difference in the immune response? So now see the apologize slide, because this is a lot of details that these guys gave me. They based it on flow cytometry. And Sebastian's lab is, I think, one of the leading labs in Germany. It is a leading lab, together with Kiel. But they have something which in Europe which we call Euroflow, which is a research part where all the flow cytometric major institutions join to one consortium, and they define antibody sets, obviously, but also different combinations and guidelines how to address and how to examine your blood in these sets. And I think that the current panel that we are using in hematology is composed of 11 different tubes having 6 to 8 markers. Within the different tubes we have some backbone markers for comparison, but it's a lot of different markers. And so they analyzed the antibody signals with flow cytometry depending on this parameter. And what you can see over here is that in general, as here we have this vector one time, and with the RNA vector, we go down here, with the activated T cells. We see that the population, at least in these cancer patients, the population which got the vector-based vaccination got the more potent active T cell response. Which this was, for some people, really surprising, but it totally tells us that at least in cancer patients with an hematological background, we are seeing if the cancer is ongoing a better response to vector-based vaccination. We have to take this with care. So it's 200 people, it's not 4,000 people, it's 200 people, but as a whole it was difficult to get them, whatever. We are currently expanding this to patients. And the groups are not equally distributed, so there is a shift also in the number of patients that we see. However, it is interesting, because it can be that we are going into a situation where maybe depending on the hematological cancer, you could be taking the vaccine. Are you guys still vaccinating for COVID? Your young people? It's a sign of that. Yeah. So I was so why can't we not really BioNTech? BioNTech was the Johnson. So then with AstraZeneca and so I think that in Germany we don't have any concrete plans for vaccinations. So you can do it if you want. And the insurance companies are still paying it. I don't know how long, but they are not anymore paying the testing costs. So we're gonna see what happens. Okay, good. So the take-home message of Sebastian's study is that at least in these parts of vaccination in our cancer patients from the East German study group, we are seeing an advantage of the rapid vaccinations. And I think this is a recommendation so at one point at least for our communities, we're going to see if this is really a bigger study, this reflects the same dynamics. But I think it's not too bad, especially Sebastian since it's too Okay, good. This is how I job. Easy as I thought. So I'm nearly finished. But I was thinking this is my second time in Hong Kong and I found this really amazing. Food is amazing, landscape is amazing, technology is amazing, HKU is amazing, everything is amazing. And then I said, okay, what do these guys do not have what we have? I can be sure. And it took me some while of thinking, but I found it. Winter. So we are located, as I said at the beginning, of the North Baltic Sea, and we get very cold winds directly from Russia. Yeah? So in bad times we can be easy minus 14 degrees in winter or lower, and as the wind is strong, we would have the feeling that it cuts your face. So this is me coming from the clinic direction to home. And we have Hansa Rostock, which is second division, so we are not the top football league, we are the second football league also. And this is us when I was the first time here in Hong Kong. It was Hans who tried to join today, but I think with the air conditioning there were problems with his throat. And if Hans would be here, you would be seeing that these guys did not change. So it looks the same as he did the first time. And this is Christian Johanns, which is the head of the Comprehensive Cancer Center in Rostock and Mecklenburg, and also the director of the clinic where I'm working in Rostock, and everybody here. Christian and he will be here in November when the scientific meeting is, which is along with this. And this is me, and I put some weight on. So I'm the only one who changed now. I have like 10 kilos more. And we are having exchange with Chinese students. So this is 3 of my PhD students, which we have in the lab since 2016. And so I'm aware of some Chinese traditions and can say Ni Hao and things like this. And if somebody serves me a cup, I will be making this. So, but there's an ongoing living cooperation within, especially within our research group Hong Kong, and we are very, very open and welcoming students and also researchers for exchange. And as we discussed the last days, traditional Chinese medicine is something that we don't have routinely in Germany. So if we have people like Hans who are integrating clinical research, it's research and clinical care. It's very good that we can be learning a lot. Especially if there is people from Hong Kong coming to show how they do it and how it is integrated into the medical care and combines it with the conventional Western medicine that we call it. And the basis for all this is the future of city. So people having a glance at it, growing, watching, exchange of students. So okay, thank you all for listening. And I hope that I could give you like an idea how German research is structured, where do we get money, and which possibilities there is to develop a deep and further online cooperation. And at this point, I'm a couple of minutes early, but I would be happy to take them. Yeah, sure.
In the beginning, you talked about the other institution that is very good in Rostock data science or data analysis, right? So, in fact, in our university, Professor Ian Wong of the Oncology is also really strong in data analysis. When you talk about the vaccination program, in fact, what he's done is really major data analysis on vaccine applications. So I was thinking whether we could work with them and we join hands together to look at one very important point is the use of Chinese medicine when patients is cancer. A lot of people don't actually tell the doctors that they're using it. They may be taking them either as food supplements or anything. So that be an area for collaboration.
Yeah, this is a top area of collaboration. Because we can learn different paths of it. Especially the average German patient will not be taking Chinese medicine. Maybe he's taking some food supplements. But a major challenge in this is that I think a lot of medical doctors are not aware that it is a good tool or a good possibility maybe to integrate things like Chinese medicine. Yeah. Yeah. Or alternative things. I was discussing yesterday with one of the Hong Kong people that we have special problem in China. We don't have a certified degree or a paper which qualifies you as traditional Chinese medicine expert or doctor. So everybody who wants can say, I'm an expert in traditional Chinese medicine, and this is a very, very bad thing in Germany because there is no regulation. So there's a lot of people making money with it. So it's possible that people are also taking some of these things and they will be not telling the market. So it's solely important. It's very, very, it's a good idea. So if there's, we can exchange the name, I will be happy to do it. Sure, go ahead.
Right. In fact, there is a very active group in Europe and Germany called the Good Praxis Traditional Chinese Medicine Research Association, GPTCMA. And the first founding president is Professor Richard Bauer of German, who is now in Graz. He's heading the Department of Traditional Medicine Research and Innovation. And then this research association first funded by EU Framework Program 7 on the program called HKUSCM, which is genomic unit. We're talking about new science. So you see we have a couple of journals, fighting medicine, right? Also, actually, a German professor, right? Office. Also, pattern pharmacology is really just done. So these are all German publications. So maybe we could actually talk about how we have worked together to get this.
So, it's a pity that Hans is not here because he is an expert in this. The German Cancer Society, which is the leading society for cancer care, and gives also the treatment standards and stuff like this. In the annual meeting of the German Cancer Society, Hans has an own spot where he meets with integrative people. And so it's structured by the German Cancer Society accepted, and the practitioners who are using alternative medicine, as they call it in Germany, including TCM, meet there. So there is a structure that and there are obviously also some small groups. Hans is also a lecturer and practitioner in Stuttgart, this is the other part of Germany, and they are active in this. But it's not part of the routine clinical care, and it's not part of the routine mindset of the oncologist. And we are trying to work on it so that it gets more research. And research it's single projects for example, but if you go to a bigger university, they will be saying, okay, yeah, there's one project and it's European and it's important, but we trust in our authors. And I think it's a very good idea that if we join forces, which all partners that we can and are available, we will be having more success. And so it's very, very welcome to be part of the exchange. And I hope maybe Hans is coming still, he was not feeling that today morning, but he would be the obvious person to talk to. However, if we exchange contact data, we would be totally happy. Okay. So I will be sticking around so somebody wants something. Thanks for listening.
Maybe we can have a 2 minutes break.
Okay, after the break, we have the second seminar of the day. The speaker is Dr. Asuna Cuisine, who's the head at Palliative Care Unit at Rostock University. Her topic today is the palliative care by integrative medicine.
Thank you. So I want to take you away from research, since I'm a clinician and I really want to go into the German perspective of palliative care, which I believe, I'm not sure, but I believe it's totally different than what you have in palliative care in Hong Kong, probably. So it won't take 1.5 hours for me to have this speech, and I hope we can get into exchange after my speech. But first, a couple of words about me. I'm Ursula, which is impossible for you to pronounce, I know, but actually this is Latin and means little bear, little female bear, which is kind of sweet. That's why my parents gave me this name. And when I always wanted to be a doctor, medical doctor, all my life. I can't think of anything else that I ever wanted to be. Not an actress. I always wanted to be a doctor, to help people. And then I got into medical school and I was impressed by all the technique of intensive medicine. And I went into anesthesia, and I did my specialization in anesthesia, and then unfortunately I had to realize that we don't really help people, or maybe the goals of intensive care is not clear for the people. And I saw a lot of people being operated and not knowing where we're going, and having chemotherapy without knowing the goals of the therapy. So I said, well, no, but this is not what I want to do with my patients. I want my patients to know what's going on, and I want to be honest and always have the goal discussed with my patients. So I came into palliative care, and I've been doing this for, I don't know, 15 years, something like that. So I'm totally a palliative care medical doctor. This is what I want to do. I do teaching with I love teaching. This is my second leg that I stand on. I love teaching. Maybe palliative care by itself would be too sad all the time, but since I have my students, that's fine. So I have some distraction from palliative care. So this is what I want to do: teaching palliative care, getting people into palliative care, and doing palliative care, being there for my patients. So why palliative care? What is that? I know this is a long definition, and I want to go through this with a couple of breaks to explain what we're doing. Actually, a palliative care specialist is a specialist on quality of life. That's the most important thing, and this is the World Health Organization's definition of palliative care. The first thing that it says is that we're like approaching quality of life of all patients and families, caregivers, friends, whoever cares for the patient who is facing the problems associated with a life-threatening, not a life-limiting or anything life-threatening. This could be an infection as well, COVID illness. So people might die from the disease. They don't have to die, but they're life-threatened ill. So this is very interesting, I think, because people always expect, when I come as a palliative care specialist, they always say, oh my gosh, I'm going to die. No, not yet. First you live, and then you have to die. Everybody has to die, but first we want to talk about your live and your quality of life. That's the most important part. Well, it's in Western medicine, I don't know about you, but in Western medicine, it has to be there. For the last, 40 years, palliative care is a fundamental part of medical care, people-centered, and it's holistic. It tries to be holistic. It tries to focus on the quality of life, on patients' wishes, and takes care of everything that the disease does with the patient. It takes care of the physical problems, pain, dyspnea, vomitus, nausea, everything of the psychological problems that the people face. Why am I affected? What could I do with my life? How is it going on? Everything, all that problem. Social, for example, 45-year-old husband, the only one that earns money, three children, a house, a lot of that. So social problems and the spiritual problems. Where am I going next? Why did this happen? Am I going to see my parents again? So all the spiritual problems that we are faced, and it is ethical responsibility for every doctor to take care of all these problems that patients are facing. And a lot of people think of cancer, and we talk a lot about cancer, since most of my patients, 9% of my patients, are cancer patients. But nowadays, it has opened up, palliative care has opened up for more patients other than cancer. Cardiac failure, drug-resistant infections, could be tuberculosis, could be other infections, severe burns, liver failure, end-stage chronic illness, whatever, diabetes. It could be acute trauma, could be very acute, what happens. And also children can be in palliative care prematurely, very early babies. They need palliative care as well, and the parents. So it should be to everybody who needs palliative care, and it should be available in all different levels of medical care. And why is this important? I think this looks, it's the age pyramid, and it looks like this in Germany, but it's pretty much what it looks like in Western Europe, in the US, and in China it might even get worse as we learn it. So people get older. Why do they get older? Because medicine has improved. Cancer care has improved. People get a lot older, nutrition is better, and we take care of ourselves. We have a work-life balance, all this, so we get older, a lot older. But still, there's diseases like chronic heart failure. And people get older, get sicker, but they live with their illnesses over a long time. But what they do have is symptoms, shortness of breath, pain, all this. And that's when they need me. That's when they need palliative care, because they do have a long life, but they want to have quality of life at the same time. And that, over the years, I said, over the years it changed. Back then in the 18th century, 700 something, what doctors were doing in Europe, they could spend their time with the dying, and they could give some rest and hope that the pain wouldn't be so bad, and they really couldn't do anything but be there and stay with their patients, but they couldn't do a lot of medical interventions. But nowadays, we all specialized, and we had technical advances, and everything changed, and we came into the organ-centered medicine. So we have experts for lungs, experts for hearts, experts for cancer, experts for research, experts for everything. And as you in China forgot about your Chinese medicine, we in Germany forgot about the caring. We got into the specialization, we got into the organs, we got into the humans, and we got into the diseases, and we have the disease organ-centered medical management. So we look at the single tiny little diseases and the causes of that, and then once a patient can't have any medication anymore, for example for cancer, so we can't cure the cancer and we don't have any chemotherapy anymore, then the doctor says, well, I can't do anything for you. There's nothing I can do for you. You're done. And for patients, this is not acceptable, because they don't want to have pain, they want to have quality of life, they want to go on, they have to be cared for. And we totally forgot about this until the 1980s around. Then palliative care came back into the mind. Just an example over how medicine changed over the years. This is cancer. We will stick with cancer all the time. Probably my patients' examples will be cancer patients as well. But in the early beginnings of cancer therapy, there were only 4 medications that we had. And a lot of people died of them. They're not really good. And nowadays, we have patient-centered medicine. We can look for the molecular characteristics of each tiny little cancer cell, and then we can tell the patient, you have to have this, you have to have that, and you can live with that over years. And even if we have a patient 80 years old, breast cancer, bone metastasis, a lot of pain, they can live with that. They can live with that and die with that disease, but not of that disease. So there's a lot of need for palliative care, for extra care for our patients. And this goes on and on. This is 2015, and since then we have, I don't know, it's just exploding, and nobody really understands all kinds of different cancers and all kinds of different cancer therapies. There's no way. So let's go back to the goals of palliative care. This is Cicely Saunders. She's English, she's a Dane. She was, the Queen made her a Dane. Cicely Saunders. She lived until 2008, from the beginning of 1908. That was when she was born. And she went to the World War II as a nurse and took care of dying people, injured soldiers. And she noticed how people just die and have pain and are not being cared for. And she said, this can't be a good idea. And she got money from one of the soldiers that was dying, and she studied medicine and social medicine, and then she founded the first hospice in London in 1967. And what she wanted it was that we had a high person, low technology approach. Yes, we do examinations of all patients, we do ultrasound, we do computer tomographies, all this, but the most gain is the patient-centered personal care. That's what she said, that's the approach that we have. We need a very good symptom control. If you want to have quality of life, you need to be free of pain, you need to be free of dyspnea, you have to feel good physically as a person. We need continuous care. In the beginning, at the very beginning of palliative care, one doctor tried to be there for his patients, for her patients all the time. So they ran out of power and this wasn't good. But we need continuous care for all our people. That's very important. We need to be there for the patients. They need to have a person that they can talk to all the time. Individualized, we heard that. We need individualized, patient-centered, goal-centered care for our patients. We need volunteers and coordination. Oh, this is coordination of the care. Somebody who's taking care of where's the patient going to be, who's taking care of that, what can we do? We need supervision for the caregivers because we run out of power after a certain time. And we as caregivers, as professionals, need people to talk to and to listen to and just get rid of all the stuff that we're hearing. And we heard from Hugo about the study of the digitalization on the palliative care unit. So we need that. We need somebody who's looking after us as professionals. We need research, of course. And we need teaching and training for our students. Since in Germany it has been obligatory for students to learn palliative care since 2013. And we need to go on with that. Yes, and we need evidence. We need, whatever we do, we need evidence that this is right and we are not harming people. We don't want to shorten life. We want to have quality of life. We want patients to live with their illnesses for a long time. Cicely Saunders accomplished the total pain concept. Total pain, I just want to remind you, these are the 4 parts of the pain that she said are present. So that's the physical pain that you have because of metastasis in the bones, for example, but it's also the spiritual needs, the psychological needs, and the social pain that people can complain of. This is really important when you do symptom control. It's not only the pain, it's all kinds of different symptoms. You have to think about the different parts, where it comes from, the psychological problems, spiritual, all this together makes the pain, makes the disease for people, makes the burden of disease for people. So let me take you to Rostock for a while. So we're going far away. You saw where Rostock was, remember, at the Baltic Sea, middle of Europe. We have 14 beds on our unit. One senior, that's me, and one intern all the time. They're rotating, they're all going to be cancer specialists. And this is not easy for me, since they just want all 3 to 6 months, and after 6 months, I have a new intern. And what they do is they keep running. Like they have been on the cancer station, on the cancer ward. They always, oh my God, we need to do it. And we need to investigate this. We need to have blood samples. We need to do this, that. Everything is possible. And I have to tell them, no, brakes, slow down. You don't need all this, because what's the goal? Where are we going? What's the patient's wish? So every 3 to 6 months I have to stop them down and say, relax a bit. Talk to the patient, what do we want? What do we need the computer tomography for? What do we need the ultrasound for if we don't do anything with it? So that's a lot of work to get them into the palliative care thinking. And we have 14 nurses. Most of them do have the specialty, or palliative care specialty. And then we have a lot of extra service on the ward. We have one psychologist, a psychologist, and she's taking care of our patients. And we have social service, of course, physiotherapy, and music therapy. I want to take you, since it's so special, I think, and I want to show you a film of our ward. I hope it works, just now it worked. And so this is just a short visit, just 2 minutes, but it's a tiny little film with something you don't have to listen, but you have to read. I hope this works. Cross your fingers. Just a tiny impression of our ward. I made this film for my students, since usually we take them on the ward. Then the pandemic came and no students were allowed. So, but I wanted to show them the specialties of the ward. So I made this film, and I had to translate all of this. And but I think you have a tiny little impression of what we do and what the specialties are. Yes. Well, talking about integrative medicine and palliative care, you always have to think about the phases of palliative care. So this can be very different depending on what's going on. It could be only minutes to hours or it could take years, whatever, and everything in between. But I have to explain to you this graph, since you probably don't know it. People notice something's going on, something's wrong. Maybe you can lose weight, have night sweats, fever, whatever. So they visit a doctor and then they get a diagnosis. And the diagnosis could be that they're just being cured, or at least if we try to have them cured, so they have a curative setting, and that we find. But a lot of patients, and all palliative care patients, they don't aim at cure, they aim at life-prolonging medications or treatment. So in over the course of disease, at some point they'll be getting over into this second part, life-prolonging, but not cure. And then at the very end, of course, of disease, during the last time, can't say how long this is. It's only supportive. We wouldn't do anything life-prolonging, but we'd do a focus. We'd have a focus on supportive care, which means symptom control, quality of life, quality of dying, but no life-prolonging medications anymore. It used to be, back then, before Ms. Saunders came, used to be cure, supportive, maybe not dying. So it used to be blocks like this, very stiff blocks. And nowadays the thinking is, where are we at? So we always have to be thinking, are we going to, what is the aim? Curative? Can we cure the patient? If not, can we still do a life-prolonging treatment without harming the patient? We always have to think about this. And then at the end, is there a chance to have a good symptom control, even though the patient is very, very sick and very far into his disease? And then the patient dies and is dead, and then we still have to grieve of the caregivers, of the families. So, and this can take, as I said, could be minutes to hours, maybe sepsis, some infections, car accident, bleeding, whatever, stroke. Could be very quick, but still there is needs for palliative care. So that's why all the emergency doctors in Germany should have basic knowledge on palliative care. Should have. And then it could be weeks, still very short time, but you still have a lot of possibilities to react and to do stuff. And as I said, could be years. There's a way that we have years of palliative care. And then in each time, of course, it's very individual, but the needs for palliative care during this course of disease could be very different. Could be in the beginning, people hear, you have a disease and you won't get rid of it. It won't go away. You have the disease and you will have to live with it and you will die of it, or maybe die with this disease, but you're faced with a disease that won't go away. This is very frightening for people, and they're shocked. So this could be that the oncologist, for example, can't take care of all the needs that the patient has. Fear, what am I going to live, who's going to take care of me, how's this treatment going to be, and all this. So this is where actually the palliative care specialist could be involved at the beginning, at the very beginning. And then everything starts, chemotherapy, patient is fine, knows how it works, knows all the people, knows the schedule and all this. And then it could be that there's no need for palliative care at all during the whole time until probably here. And there could be no more chemotherapy, no more oncologists, no more appointments with the oncologist, and then the medical doctor at home, the home doctor doesn't know anything. So then it could be that the palliative care specialist needs to be there. Or it could be that there's a lot of fear all the time and a lot of needs for talks and all this. So that the palliative care specialist could be involved all the time, or maybe not. That this works, there's a lot of evidence for palliative care specialists to be involved into the whole process. And I don't have this, but there's a lot of evidence that this is a really good thing for patients. They come better through their chemotherapy, they have a better understanding for what's going on, for how they can talk, they're more open for talks, for their own symptoms to show them and to argue about them. And then we have to make a difference about the age of the patient. Actually, we're not supposed to. So we're not supposed to tell the patient, well, you're, I don't know, you're 120. Maybe it's time for you to die. You have to think about it. But patients don't think about dying. At least in Germany, dying, the whole society is not aware of death or sickness or illness at all. So we just leave that out. Everybody has to be healthy, everybody has to be beautiful, everybody has to be skinny, nobody's ever sick. And death, we just don't talk about it. People that are sick, they're just outside the society. And we don't want to talk about that because it makes us really sad. So once the people get older, then the doctors, medical doctors expect, well, they have to have heard that at a certain age, people do die, but no, they haven't heard about it. So we're not supposed to make a difference, whether there's somebody 40 or 80. But still, I think there is a difference because people have a different social background. And there's other caregivers, families with different needs. So we have to look at the age, especially for the social network. I can show you. If there's a baby, then there's a lot of family there, a lot of parents, siblings that need to be taken care of. If the patient is 45, the family might be very, very important for this patient. They maybe has teenager kids at home that he needs to take care of. They have school needs and all this, then there's a wife, and then he still goes to work. So there's a lot of needs there that he has to think about, the responsibilities that this 45-year-old man has, for example, and hobbies, of course. And then there's still society that expects him to be healthy and to work, to his job, and to be there, to be present. But then the elderly, whatever person, probably wouldn't be as much involved into family. Maybe she or he lives in an elderly home. There's not so much dependence in between the social networks, so she's by herself. She needs a lot of care, or her or he, and then she doesn't go to work and all this, and so there's a totally different aspect of who is involved into the care, especially if we look at the families and the social network. And I want to discuss this with you at the end, these points, because I think, I don't know, but I have the feeling that this might be different in China. So that the whole support, the network could be, I think, maybe different in China. So I really would like to discuss this with you at the end. In Germany, there's different structures of palliative services that we use. We do have the specialized palliative care done by palliative care specialists like me. And then we have the general palliative care that is done by medical doctors, like family doctors or specialists in cancer or whatever, pulmonary specialists. But they only have basic knowledge on palliative care, but they still have to do the general palliative care service, like symptom control in a basic way. They don't really have to go into it very deep. And then this is the two sides of it, the general and the specialized care, and then there's inpatient and outpatient care. The inpatient is the palliative care unit that you saw just now. This is where I work. We have a unit separated from the hospital, everything nice, beautiful. This is Wonderland. Everything's there, so people are taken care of in a very special center, patient-centered, nice, calm way. They can sleep in, they can have breakfast whenever, they can, everything's nice, beautiful. But this is not the reality for everybody. Then we have hospice. The hospice is a very nice place to be, and hospice is a very nice place to die, but that's the goal. People go there, we have to apply for it, and people go there to die. So what we don't do is we don't do any investigation, we don't take blood samples anymore at the hospice, all we do is symptom-centered, symptom control medications. That's all we do. Is they have fever of an infection, we put down the fever, and we wouldn't do anything against the infections. If they have anemia, they wouldn't get any blood. So it's just symptom control. That's all we do. Then we have the palliative service. That's palliative specialist. My colleague does that, and they walk on into the different departments of the hospital to visit patients in these departments and to supervise what the general doctors, the specialists for other services would do, but the patients would not be on my units. Most of them that are visited by the palliative service would come to my unit at one time, but the goal is that we can talk to the patients on the other units, and be advise the doctors on the other units. So just spreading the thought of palliative care into the hospital, into the other departments. That's pretty nice work. We see a lot, we talk a lot. The nurses really appreciate it. The doctors, they don't get into it. They're just too busy. But the nurses really appreciate it. They're totally happy about us coming and telling them. And there's always a doctor and a nurse coming together, two specialists of palliative care, going into the different departments and talking to the colleagues. Pretty nice thing. We implemented this last year. Nice thing. And then we have the specialized outpatient palliative service. This is where I work as well. I work on the units, inpatient. And then I have my patients in the outpatient setting, in their families, which is a problem in Germany, since families are spread all over the place. Not only Germany, but Western Europe, China, US, Canada, wherever families go, they spread out. They don't stay at the place where you were born. Most students, anyone from Rostock? No. So that's what they do. They grow up elsewhere, and then they move wherever. Medical students, they get their study place wherever, so you can apply for certain cities, but you don't usually get that. So a couple of students go to Rostock and come from Munich or wherever. So you spread out, and you want to see the world. You don't want to stay in Rostock or wherever. So we have elderly people living by themselves. The kids are all over the place, and they don't have anyone who's taking care of them really, so they're all by themselves. So when I come and say, well, you could be discharged from the unit and go home, then they say, well, by myself, I can walk, I'm too weak, I'm frail, there's no way I can take care of myself. Then they have to go to a nursing home. But the nursing homes are very rare. So once in a while we do have problems. So my main part of my job is to talk to people. You won't be able to go home by yourself. You have to go to a nursing home. People don't want to go to a nursing home. Of course, it's not private. It's not your home. And then we have to tell them, and we don't have any spot in Germany, in Rostock, so you might be elsewhere around. This is not what people want. You shouldn't swap old people around and take them away from their home. But this is what we have to do since nobody's taking care of them at home. So we have the specialized outpatient palliative service for nursing homes at one place, because the nurses in the nursing homes don't have the palliative eye, they can't do symptom control really good. So they can take care, they can clean, they can wash people, but they don't have the certain knowledge on symptom control. So that's what they need us for, to help them doing the symptom control in the nursing home. Or we can discharge them home if there's anybody who's taking care of them. And then we have the general outpatient palliative service, which the family doctor does, which is basic knowledge on palliative care, but no, he or she is not specialized into palliative care. Yeah, what do we do with integrative medicine? There's not so much Chinese medicine at our palliative care service. We're so lucky to have Hans with us, who once in a while comes and does some acupuncture and maybe some decocts, some teas or something, and helps the people. But this is the patient usually have to ask for it. So once in a while I think about it, and then I say, well, maybe Hans could come. But most patients don't really have access to Chinese medicine. So this is not the main part that we do with integrative medicine at my ward, my unit. So we have to open up our minds to integrative medicine. What is that? It should be evidence-based. What I show is not all evidence-based. Some is common sense. It must be good. It doesn't harm. So, but it should be evidence-based and evidence-based approach to treat a person who is sick. Mind, body, soul. There's again all the needs, total pain, remember. So we have the physical, emotional, mental, spiritual needs that the patient needs, that the patient has. And all of these needs are present for the patient, so we need to address those needs and use a combination of conventional Western medicine, what we do a lot, this is what I do all day, and involve other therapies patients ask for. So it could be complementary therapies, conventional complementary therapies, and this is all what belongs to it. This is another picture of that. So we have conventional medicine, what I do pretty much all day, and then we have complementary health services that patients, usually in Germany, use a lot on their own expenses as well. And this is not really structured well. So patients, usually they have to look it up at Google, and Google says a lot, and they don't know which is wrong and which is right. So they use everything that they can reach, and could be expensive. People spend a lot of money, unfortunately, for complementary health care, and we don't really, and there's no evidence once in a while. So there's a lot of whatever, healing and all this. And then what we teach our patients is self-care. So this is a crucial part of medicine and of palliative care, is that they have self-care. Who says I'm not healthy? Why am I? There's just a tumor, and I'm a healthy person. So we can do a lot on this part, self-care. This is a really, really important part of what we do all day, self-care. Except. Yeah, and this is what I'm going to talk about is, I want to tell you something about the self-care and the self-awareness of all patients. And then I want to tell you a little tiny bit about the pharmacological support therapy that we do, which is a lot of off-label use, of course. And why is this so important? Well, we have we're faced with desperate patients. Patients got told, well, there's nothing we can do for you except palliative care. This is what they often hear because we want them to be there. We want to be there early for the patients at the point of diagnosis. Remember the graph I showed you, we want to be there at the very beginning and tell them, well, you won't be cured, but no problem, you'll be fine, your life prolonging, everything, and we're just there to support you. But that's not the way it works, unfortunately. Unfortunately, doctors do a lot of stuff, a lot of things, life prolonging, and then at one point they say, well, now we're done. Now you can go to Dr. Friesen. She's the palliative care specialist. And then that's the very end of the course of disease. So this is, I'm the ghost that always, that's in a patient's mind. Oh my gosh, palliative care specialist comes and I have to die. Unfortunately, that's the way it is still in Germany, even though we know better, and everybody knows better, and everybody's taught, oh my gosh. There's still the palliative care variant, last weeks of life. But then as the patient is told this, then this is great, and they don't want to be here. And what they want to reach out for hope. That's the main part. I want to be where the grass is greener. I want to have hope. I still want to do something on my own. And if the doctor says there's nothing I can do for you, then at least I want to do something. And I think this is where we have to work on. We have to be with the patients to say, well, the grass is as green on that side as on this one, and you won't be cured. And there's hope all over the place. But we have to talk about hope for what. This is what we need to work on. So we need to be honest with our patients, and if patients requests for whatever medication, then we need evidence and we need knowledge on alternatives, and talk to the patients and tell them this is good, this is not good, and we can do this and that, and this is the goals. And I think this is very important. You can't stand on one leg, and if this leg is taken from you, then you have to be there and give it back. Very important point. So what we do is we work on self-care for our patients. They need to learn to deal with the disease, to deal with the end of life that's coming up. And we have our psycho-oncology. I don't even know whether this is a word that's right. We use it in German. Normally those people are psychologists, like her. She's the one that works on our ward. And they actually help people dealing with the disease and with the course of disease and with side effects of chemotherapy. They do moderation between the family and the patients. For example, patients often don't like to eat. They can't. For some reason, they can't eat. They lose weight, and families would always say, well, you have to eat. All you have to do is eat. Then you don't lose weight. But they can't. There's tumor and all this, and they can't eat. No way. And this is a stress factor for the patient when the family always comes and brings them food and all kinds of ice cream and whatever, and they don't want to eat. It's just they can't. It's not that they don't want to eat. They want to eat, but they can't. So this is where a family needs moderation, and they need somebody who just explains to the family, well, this is nice of you to have all the food here, but the patient can't eat. It's just can't. And this is what she does. She takes care of the patient, the fears, and everything that the patient goes through. She explains what the doctor said to the patient, because the patients often don't remember or don't understand, and patients don't know. They're totally distracted by all the new things that are going on. So this is what she does. She helps professionals talk to patients and family members, and she helps patients talk to doctors and other professionals. And she helps a lot with decision making. It's like, so where do you want to live? I could ask my patients, where are you going to live? Who's going to take care of you? The patient doesn't know. This could take a while, but like maybe weeks, that the patient doesn't know. And then she helps, and she puts on all the different alternatives and says, well, what would be best for you? And so she helps getting things and thoughts straight out to where the patient's going to be. Very, very helpful, important. We could never like miss her to talk to patients dealing with all these difficult situations and decisions that need to be made. So she really helps us strengthen the dealing with disease in this palliative setting. Very important. One most important thing in palliative care, this is what we train in 5th semester, like very beginning, right after the preclinical education, first semester, then we have to, like, we teach the students how to talk to patients. We do patient talks, doctor-patient talks, the SPICE model. Because it is so important that patients know where they stand with their disease. And it sounds so simple because you probably think that every medical doctor would always communicate with their patients. Well, this is the possible treatments that we have, and that's the goal. That's the goal. This is where we want to go. And this is what we can reach. And there's nothing above this. We can't cure you. It's just maybe life prolonging, maybe less pain. That's the goal. And I'm always surprised, but maybe it's not communicated. I don't know, maybe patients don't understand, but I have a lot of patients who say, well, I want that treatment. Why? Why do you want that treatment for? What do you want that treatment for? Well, I want to be cured. A lot of patients say that in a palliative care setting. When I say, well, there's no cure, no way. You're not going to be, maybe you have 2 more months of life, but that's it. You won't be cured, and it's not a lot of benefit. Then they realize, oh, maybe I don't want that therapy then in this case. So we need to tell our patient what the treatment is. An effective treatment can be very beneficial for patients, but don't have to be. It could be that a patient says, well, if there's only 2 months of life prolonging, then this is not what I want. All I want is to be at home, to not to have nausea, and maybe to get up once in a while. If they get chemotherapy, then they have nausea a lot. They spend a lot of time at the hospital, and they don't feel good, and they get frail. So maybe the patient says, well, all I want to have is my birthday or Christmas. Christmas is always a big thing for Germans. Christmas is. I want to celebrate Christmas the last time, and now we have September. Yeah, well, if we don't do the medication, if we don't do the treatment, then maybe you have Christmas. We don't know. Nobody knows, but if you do the treatment, it's the same, pretty much. Maybe you have 1 month more. So we always need to talk about the goal of a treatment to the patient. And then the patient can decide. This is very important. I have to show this my boss, Christian Junghans. He's the professor of all of the comprehensive candidates and all our boss. He always shows this to the students. The students know this. The patient always needs to be the captain. And only a patient who is truly informed about what we can do and what it means to him doing the treatment and what the goal is, the benefit. That's the patient that can decide. German patients usually are not good in deciding. I often hear, well, you're the medical doctor. I don't know what's best for me. But we really have to get them into this thinking. You're a patient. You have to know what you want to do, what the benefit is. So this is really, really important. Of course, there always needs to be medical indication for every treatment that we offer. We can't offer whatever operation if there's no operation to be done. That's simple. And there needs to be a patient's wish for every treatment. Yeah, so the remaining time might be short, but in Germany a lot of patients want to know how much time they have. A lot of patients want us to be honest with them about the time that they have. We don't know really. We can talk about days, maybe weeks, maybe months, years, but a lot of patients want to know that. That's difficult once in a while, but we have to tell them how much time they have and how much time benefit they will have from treatments if we talk about cancer. Yes, and we need to be honest, which is very difficult for me once in a while to tell people, you will have to die. We know you will have to die, and it's only very short term, maybe only days. That hurt. It hurts me, it hurts my patient, it hurts the families. But we need to do this. We need to tell patients where they are in their disease and what we can reach and what we can do. Nutrition is a very important part. This is what people are aware of as well. I want to be healthy, I want to have a good nutrition. And there's a lot of very uncertain, not good, the cancer diets and all this that is very unbalanced once in a while. No sugar, no whatever, and then they eat all different things. The companies earn a lot of money for this, but there's no benefit for our patients really. What we really focus on is the socializing effect of eating. You see the old people there, they come together. My family always comes together for eating. I don't see my 3 sons, and I don't see them a lot, but when we eat, then we see each other, we talk, I can hear what my sons don't really speak too much, they don't talk a lot. So it's a yes and a no when I ask. But then at least I get a yes and a no at eating time. So, this is important. So this is important for families, it's important for people to come together and eat. So this is a really, really socializing effect. And we need to think about eating to be fun. And that's why we try our patients to have fun eating, maybe little portions only, just one potato, one tiny little bit of meat, one tiny little bit of vegetables, but they eat something. They should have a balanced diet with vitamins, elements, fat, but we still have a parenteral nutrition as well, of course, for some patients. And it's always good to talk about nutrition all the time. For patients to be aware of the socializing effect and maybe get rid of the parenteral nutrition at some point of disease at the very end. Self-awareness is a very big problem. You saw this slide, I know who will show it as well. Sabine is she's a sports scientist, and she takes care of our patients throughout the disease, during all stages of disease, at the very end, at the very beginning, also palliative care patients. And the goal is to keep them out of the bed. We don't need frailty, we want them to be active. That's the one major part of self-awareness, is to be active, to have their muscles stretched, to be out of the bed. They feel good, they have more self-confidence, self-awareness. This is a really, really important part. I know this is all in German, but Sabine, she should come here one day because she does great work for our patients. She's there. She does this inpatient, for our inpatients. She comes and practices with them, and then she is always there for the outpatients, cancer patients, to consult them and train them how to use sports at home. We do position our patients with the bullet concept. You probably know that. It's more for patients with strokes, but since a lot of people have metastasis in the brain or in the bones, in the spine, they could have a numb limbs. And this is what we use that for, so people can touch. They can move their legs, they get positioned after this concept. So they're self-aware of their numbness and the other side. And this is a really good concept that we use, that the nurses use all the time for the people to get into their disease and to feel the numb limbs, the paralyzed limbs. And the other concept that our nurses use a lot, that I'm not so much into this, but the nurses do it a lot, is basal stimulation, which is everything at once. It's just pretty basic, actually. They use it for to stimulate all different kinds of senses, and they try to move the patient, communicate, to strengthen the perception of patients, especially after stroke, but for all diseases actually. So when we enter the room, we first tell the patient, even though he might not be conscious, we'll tell the patient, well, this is the ward round now, I'm Dr. Kriesen, good morning, it's 8 o'clock now, whatever. And then we touch the patient at the shoulder. And not at the paralyzed shoulder, but at the good shoulder first. Now we're here, we want to examine you, whatever. What the nurses do is, maybe they take some honey, for example, if the patient likes sweets, and they fill out the mouth with honey from the healthy side to the numb side, so the patient can taste some. Could be liverwurst, sausage. Or Germans like sausages, or honey, or red wine. I'm a wine type. Maybe for Google we see this beer, whatever. So he can taste something. We do aromatherapy, which I will mention later on, for the smelling. Or we take out the patients out of the bed if they can. And just put them onto. You saw the stones in the film. You can put the feet on the stones so they can feel something underneath their feet, and they have a different view over. When they sit, they have a different view over their room or over the unit. And we take them out. We show them TV. Somebody reads to them. We have volunteers reading. So there's a lot of different things to stimulate, a lot of different senses that the people need and people have, and we should always be aware of the different senses. Always talk to patients and always tell them what we do. Very, very important. And one part of self-awareness, of course, is our music therapy. This is our therapist. She's really experienced doing music therapy with children, with adults, with elderly, everybody. She has been doing music therapy for years, and what she does is all this. She sings with patients, all traditional German songs that we just distracts the patients from what they're in now, brings them back to their childhood maybe. She can change breathing, even takes them, calms them down, breathe. She can practice that with them. She does vibrations. She has little bowls that she puts on the lips, for example. I had one patient once that had metastasis in the bones, and he couldn't feel his limbs anymore, his legs. And she put on the bowls, and then it was a vibration. And he said, "Oh, I can feel my leg. This is great. And it's a lot of spare time that she has. She can just spend 15 minutes, 20 minutes with one patient, and then they just get distracted and they have a lot of time together, and it's a really good thing to let emotions go. They can just cry together, talk together. And she is not a medical doctor. She's nobody with a medical background. She doesn't. That's not the goal. It's just the goal of medical. Really good help for us. And then there's aromatherapy. I told you about the smelling, and there's different impacts for different aromas that we use. My nurses usually do this. I'm just telling you this. I have to believe it. But if you, for example, if you take lemon and mint together with salt and you smell it, you can calm nausea. So the nausea will go down. So they just smell all day and then they feel better and they forget their nausea. You can do acupressure as well, but you can do the smelling therapy. Melissa and lavender are supposed to be calming. This is what we often do for patients that die. They actually wash them with melissa and lavender, and then they calm down, breathe normally. They relax. Cinnamon is mood lifting. This is what I use all the time when I'm at work. And then there's a lot of different aromas that we use for our patients to get to different goals. And this is what I do, and I don't want to spend too much time on it because this would be just too much and too distracting probably, but I put the pharmacological supportive medication into 3 different aspects, which is evidence-based, which is not so easy with the medications that we use other than the on-label use for medications. We do a lot of off-label use in palliative care, but I'll talk about this later. And then there's a couple of medications that don't have an evidence, but patients still use it, but they don't harm. And then there's a whole bunch of medications that people use that are potentially harming. And of course, normal people don't know, and we have to do a lot of research on these medications so people don't harm themselves or we don't harm people. For example, baking powder, a lot of people use baking powder for chemotherapy because they say it strengthens the effect of chemotherapy, but baking powder might be harming them. I had one patient who used our microscopy. They spend a lot of money on this, but all they do is like they take a little blood sample, a tiny little bit, and they look at it under a dark field microscope. And then they told the patient, well, you're fine, totally fine. And he didn't go and get his medication. He didn't go and get his treatment. He just stopped because he was fine. They said, this could be harming. This is not good. This is not proper. That means a lot of these, of course, you probably know all these, and I want to go into the cannabinoids later on because this is what we use a lot, and a lot of people want us to write, to prescribe this, and I want to get into this a little bit later. What we do a lot in palliative care is off-label use. We use a lot of medications that don't have the label for it. Morphine for dyspnea, for example, shortness of breath, we treat with morphine pretty much all the time. We use levomethomycin for nausea a lot. So there's different medications that we use in palliative care for different goals. And this is a huge research field that is so far not really good research. So there's a lot to do with. In Munich, there's one lady who she collects all the medications that we use and puts it into one table. So we have an overview of all the medications used for different goals, for different symptoms, and she's collecting this. What we also have to think about when we are palliative care is how do we get medications into the patients. For example, if they have bowel obstruction, they won't eat they won't want any oral medication. So we use subcutaneously, we give it to the patients, the medication, or maybe transmucolon. Always depends, but we need to have a closer look on what's working and how is it working and how can we get medication into the patients. And then, of course, maybe continuous, discontinuous. And we always have to be aware of patients' wishes and goals. I told you this. What we use a lot since maybe 10 years are cannabinoids in Germany. Patients requested a lot. Maybe I show this first. Patients want this, really, and they think it's heaven. And then doctors are totally afraid of this because we don't know a lot about cannabinoids in Germany. There's only tiny, we don't have it in medical school, we don't learn anything about it. And then there's still, it's a natural product, so we don't really know what is doing what and what temperature we set up, what. And this is really complicated, so people request it, patients want it, and doctors want to subscribe it, but prescribe it. But we can't prescribe it since 2015. We're allowed as doctors to prescribe it, but only on narcotic prescription. So it's a special prescription. And until now, until just now, June 23, we had to apply for that. And now since June 23, we don't have to apply for the prescription, but we can give it to the patient on narcotic prescription, but only for palliative care patients. For all the others, we still have to apply for the costs. For the cost, yeah, and we are only allowed to give a special amount, only, and as I said, it's highly requested by patients, but it's not, well, after my experience, it's not really working as good as we thought maybe. What I use, we have a lot of medications that are done, like THC ready for like highly cleaned, just plain THC, which is not as good after my experience as the whole plant. It's best to give them the whole plant to get all the benefits of what it does. And what I tell my patients is they shouldn't even drink a tea. I tell them to maybe eat a cookie with a lot of fat in it. So I tell them to bake something or make something out of the plant other than a tea. But a lot of people can't eat anymore. I told you about they don't want to eat. And that's one of the indications is that they don't have appetite and they lose weight a lot. This is one of the tiny little indications that I use cannabinoids for. It doesn't work. It doesn't really work for pain after my experience. We can maybe talk about it. Maybe have different experiences, but I really use it for people losing a lot of weight and getting tiny skin and having a lot of fatigue. This is what I use it for. But then they don't want to eat, and they don't want to eat their space cookies. So what I'm telling them, I give them an inhaler, and then they can inhale cannabinoids each time they want to eat, and then they have better appetite, and that works fairly well. A lot of people hope for pain relief or for relaxation. This is not really working so good. My experience says no, it doesn't work so good. And we always have to think about the side effects. Old people can't really deal with inhaling. They really want that they ask for the highly cleaned THC drops or something, and then but still there's all the sense of time, all the sense of mood. They get tired, they get dizzy, they have impaired memory. So this is what we have to take into account when we talk about cannabinoids, especially for elderly. The younger patients, they can deal with it a lot better, and they improve a lot better, and they have better effects. But the older, I don't really give it to them so often and in a good way. And it's a natural product, and so the ingredients might vary. We don't have cannabinoids so far in Germany, so we have to import them from Canada, and often we don't really know what we get, so this makes me nervous as well. So I want to come into the discussion, and I think we have 20 minutes if you're still awake, and I'd really like to be an exchange with you about China and what the differences are between German palliative care and your experiences in palliative care, especially with maybe the course of disease, which needs should be addressed at what time. What about advanced directives that we do a lot with our patients? Do we have that? Do we have problems with that? When would we probably give a advanced directive at this time so we can ask the patient to think about what happens whenever the disease goes on? And what about the needs of the patients? And then maybe this, how is this maybe different in China? Yes, so let's maybe come into a discussion. Thank you.
Right. The first thing is, it's so remarkable. Your presentation is very enlightening. And I have to tell you my background before we can go on to the discussion. I am with a patient, twice cancer. Right? The second thing is my husband died from cancer, right, 20 odd years ago, after 3 years of palliative care. Right? So that is the background. But more importantly is I was the chief executive of Primary Hospital up the road 30 years ago, and I started to employ the first palliative care doctor in the whole of Hong Kong. Right? So it was in the Department of Oncology. So we are confining ourselves to cancer. Right? So with that background, I'd like to inform you, answer the questions that we posed. The first point is, she was talking about German standard, okay? But yeah, I tell you, it applies to Chinese as well. Okay? So that is it. Chinese doctors, the Chinese patients, they're all the same. I think all over the world, it's the same. Okay? So that background is easy. Now, the second thing is, we talk about Hong Kong and China as one, but it's very different. Okay? So to answer you about China, maybe just simply, I don't know, but from my wide travel in China, they're very, very different. Go from big cities to the villages, they're all very different. But I think in general, for Chinese in general, they actually just accept hospice care. Because you go to some place to die, and people don't want to go there. Right? And you go there, and I think there are programs where they are given morphine patches and they wait to die. So they don't actually have what you have described, okay, in general. So maybe there are a few, different ones, but I think that they're not common. Right? Then the second thing is about Hong Kong, right? I think we have some colleagues here. We'll talk about the department services too. But we have a couple of NGOs, non-government organizations, that runs the palliative care. And it starts with hospice care, like gradually, but become actually, they have very nice environment like yours, right? But only very limited, and so that is difficult. But for the Hong Kong Island, South of Hong Kong, primarily associated, we have the Anti-Cancer Society, right? Again, only cancer. That has been doing it, and therefore, but in the past again, because it was like hospice, patients don't want to go because if you want to go there to die. So we don't want to go there to die. We want to go back home, as we said. Right? But the difference is, in Hong Kong, our home conditions are very poor. Right? It's overcrowded. We really don't have the opportunity to relax and your family come and you can do that in your work. Right? At home, a lot of people cannot do that. So therefore, that is also difficult. So with the help of Jockey Club, Hong Kong Jockey Club is one of the top 10 philanthropist organization in the world. So they have actually funded the Anti-Cancer Society over the past few years very substantially. And so they actually have turned the hospital, which is just actually a few kilometers down the road. And they actually have a hospital now, like your environment, but not as good, okay? But they have tried very hard to create an environment for the patients. And also, they have dedicated by the community part. Even the nurses, the social workers, they go and hold hands and communicate with the family and all that. So we are beginning to do that, but it's obviously not as good as what you are doing. So that is the right? Now, then I know because I see Dr. President here, right? Because the University of Hong Kong, Department of Sciences, they run classes, right? Two things. One is actually the art therapy, music therapy, rainbow, right? So they actually run. The good thing is we have people, professors who train. The bad thing is we don't have the people to fund the services. Right? So we have music therapy, so the art therapy, but where do you get it? How do you incorporate it into the palliative care? Right? For example, we're talking about Hong Kong, I started the palliative care unit in Premium Hospital, but it's not there anymore. At the time, I didn't call it palliative care because that's the rule to the patients. So that was the first so-called cancer center. So the palliation is hidden, all right? But it was meant to be it. I have social worker who actually work on it, and we have patient groups. That's the thing that I think in Hong Kong we are doing really well. When I first started 30 years ago in Primary, we had patients who formed patient groups, patient support groups, say breast cancer. Okay, you have breast cancer support groups, right? And then other colon cancer, you have support groups. And the support from the patients and the relatives of each other actually helps tremendously. So because we just don't have the staff or the funding to support the palliative care, so that has to be done via the volunteers in the different associations. So that is the model. Then Professor Ng actually has reviewed some of the evidence for the alternative therapy that we have regarding Chinese medicine, like Qigong, Tai Chi, and the like. Right? So maybe he can talk about it later on. So in fact, I talked to you just now and said my husband had liver cancer 30 odd years ago. Right? He was stage 4. Our very famous professor in liver cancer, Professor Fancer, he had 3 weeks to 3 months. Right? So obviously we know what to do. Okay? And but then people said there's something in China which works very well, and that is Qigong. Okay? So it's actually a form of therapy that is used widely in China. So he learned it, and actually it helped him, and he lived for 3 years. He actually went back to work. He was actually the time director of the Chinese University, Chinese University. After 3 months, he actually he had ascites, dropped cortisone by cancer. That actually went through and improved, and his ascites gone. He was okay. He recovered from without surgery from the liver cancer, and lived for 2 years. Right? So that is anecdotal from a Western medicine viewpoint, but it shows that it may work. So what I did was I actually did studies on my doctors and nurses doing just Qigong before and after, and I demonstrated that with Qigong, your morning cortisol level actually decreased. That means to say there's relaxation, so your stress decreased. And more importantly is your cytokines. Type 1 cytokines goes up, type 2 goes down. Type 1 cytokines is actually interferon and interleukin 6 and that. So actually will improve your infection, your resistance to infection. So therefore, we have now a group on Qigong support patients, right? And we are actually teaching those as a means of helping those who need it.
Thank you.
What is this?
Thank you. Yeah, really thanks Dr. Christine for the sharing. I think, yeah, so we have differences and we also have something in common, but I think our goal is the same. Actually, focusing more on the quality of life of the people going to pass away, and also focusing on the quality of life of the survivors. So I think we have common goal, but then the context will be different, and then we may have different challenges. Yeah. So Professor Wong mentioned about like the physical challenges of many families, and I think there are also some cultural differences. May not be very different, but one common difference among the elderly people, not only in Hong Kong, not only in China, but also in this part of Asia, we call it the chopstick culture, chopstick region. The common point is that the elderly people, because of the collective culture, the elderly people would be more conscious about whether they will become a burden. Because in a collective culture, we put much emphasis that we hope to be productive, to help others, rather than a care receiver. So that's often a turning point in our work with those people who are going to pass and also the family. And then that critical point would be wonderful. And then we can have them actually, the family members won't see them as a burden. They see them as an asset. And that would be a critical turning point for us to work with elderly people, or not only elderly people, but people in terminal stage. And that turning point could help those people. They are they're grateful and they are willing to share their life and their needs, their desire. And then the family members could also so talking about death no longer be a taboo. So that critical turning point could be a golden opportunity for the family to be connected at a different level. Okay? And then, of course, the use of alternative medicine or qigong or whatever would be very helpful. So they could be very useful media to connect those people. Okay? And also empower them and also give them a sense of mastery. Okay? And after all, I think we have a common goal to really improve the quality of life of the person who is going to pass away and also the survivors. Thank you.
Thank you. Families in Germany would expect society to take care of the patients, and they want to be involved all the time, but they don't want to they don't want to be active. They want to be passive, visit, go away, and just be taken as, I don't know, as part of the system that needs to be cared for. But they don't want to take care. So they feel, so there is a burden for the family, and they totally express that. And they want patients to be institutionalized. So they want to be the patients somewhere elsewhere. Like very, very little patients at home, and most patients at the nursing home or the hospitals. Yes, advanced directive, we have a lot of patients don't have it. Does everybody know what that is? The patients will have disease, so they can tell what they want and what they don't want. A lot of patients don't, a lot of people, not patients, a lot of people don't have an advanced directive. But once they get ill, we have to get them into the thought of maybe it's getting worse, and maybe one day you won't be able to say what you want, and then somebody has to decide. And in Germany, it's if you don't have a directive and family, it's not automatic that the family members will take care of you. So that might be the government, somebody given to you that's taking care of you. And we need somebody to talk to. If a patient can't say anything and can't tell his wishes, then I, as a doctor, need somebody to decide. It's not that the doctor can just decide this is best and this is what we do, but we need somebody to talk to. So it might be that a judge says, well, this is a good person, like could be a lawyer or something, he'll take over the will of the patient. The patient will pronounce that. So, and this could take maybe like a couple of days. And until I have that person that I can talk to, I probably decide of the medical decision, like best medical decision. But then I have to talk to the patients. You have to have an advanced will so I can know what you want and what you don't want. But patients really don't want to think about it. What is the end? What do I want? Do I want to have a ventilation? Do I want to be resuscitated? Something like that. And this is a really big problem because people have to think about it at least once. And then given whatever they want, they have to think about their death. And they don't want to contact themselves with that. It's hard work for us to get the patients into this thinking at least once. What happens if? It's a lot of work. What I tell my patients is if you don't want to think about your own death and what you want and maybe ventilation, do you want to be resuscitated, then tell somebody what you want and what your goals are, and then have this person decide for you. This is what we have as well, that somebody pronounces the will. And I have a lot of patients doing this, that they say my husband has to decide whatever, but I don't want to decide myself, but I have my husband to decide. And since January this year, we have that the married people can decide for half a year without any special.
So maybe I could respond to that first, reflect from Department of Social Sciences, actually again funded by Jockey Club, as a large program on end of life. And they talk about the three treasures that you need, when planning for your death. Three things. First of all is a will, right? So, what you want to leave behind to your children. The other one is the advance directive. And the third one is the enduring power of attorney, right? So, maybe I'll talk about the advance directive first. We started this quite early in preliminary, but apparently, according to the lawyers, it is actually not actionable because the law in Hong Kong makes it that the patient's relatives, their sons and daughters, may not actually respond to or may object to whatever decision, such that the doctors would refuse to do what you want them to do. And now we are in Hong Kong, actually the Bureau for Health and Services actually is reviewing the law. And in fact, we had a Zoom meeting with Singapore. Singapore has done it, and it's a Chinese population as well, mainly, right? And they actually have you sign it and then put your advance directive onto your website. Because you see, we were talking about like if I fall unconscious at home and I don't want to be resuscitated, so the people who come, the emergency ambulance people, would not know unless they can actually have actual access to your will. All right? So therefore, it has to be on the website so that people could search to see whether you've got this. If you have this, then you can stop. Otherwise, if they don't do it, then they are in trouble. So therefore, this thing is not done in Hong Kong like this. It's only in Singapore. So we are talking about how to change the law. Okay? But for the enduring power of attorney, I don't know whether you have it in Germany. It's actually if I lose consciousness from a stroke, and I can empower my children to access my money so that they could get the money to treat me, for example. Do you have
like a will?
It's not exactly a will because I haven't died, right? I'm unconscious, right? So they could sign the checks to pay for the bills and all that. So therefore that one is actually very important because we have a high rate of stroke and so forth.
That's what I meant when I said
they should have somebody doing stuff like
Right.
that. This could be money, this could be whatever, banks,
Yeah.
housing.
Yeah, that's what I'm saying.
Yeah.
So, but then we know for a fact that very few Hong Kong people have done it. You know, and it's actually quite expensive, you know, to pay the lawyers to do this. That may be the reason too. So again, a lot of these social welfare NGOs are actually now trying to get it the cheapest and so that the people can do it. So that, sorry. Thank you.
First of all, very good presentation, very informative. And I come from mainland China. From my own observation, which may not reflect the true reality, palliative care and hospice care is still at the beginner stage of development in China. So a lot of this program starts from like tertiary public hospitals, and a lot of these services may be restricted to patients with cancer. So oncology doctors are beginning to know more about palliative care and more comprehensive ways of treating cancer and improving patients' quality of life. But I'm just curious about how our like PC specialists are certified in Germany, and also how and when patients are referred to palliative care. If there is an universal referral program, or who decides if patients are referred to palliative care at all.
And the second question is, it depends on, well, if the patient requests for it, then they'll get into it early. But as I said, patients are afraid of that because they don't know. For patients still, palliative care is care of dying. So people often don't request for it. So if they don't request for it, then the specialists have to take them to palliative care, to call me or somebody else, if they have to think about it. It's like me thinking of Chinese medicine enhanced, and I often don't. The other specialists don't think about palliative care, and they just do what they do, and then all of a sudden the patient is, oh my gosh, he's so bad, I don't know what to do, then I have to call Dr. Crescent. And this is often way too late. So it still depends on the thinking of single physicians. Some of them do, and some of them, most of them, don't think about palliative care and what it does. And so it's still not present in Germany either. So we don't have early integration. Once in a while we do. Early integration is a very good thing, but we don't really live it. And we have to be, like, we specialize. I did anesthesia first. And I came, well, and now I do oncology, tiny little bit, and I do a lot of palliative care. But we have all different kinds of specialists that do palliative care, urology, surgery, and all this. We have to do courses, and we have to work with palliative care patients for at least 3 months. And then we have to do an exam, final exam, oral exam. It's like a talk to specialists that we have the empathy and that we have the knowledge, and we can do symptom control, and then we get the ticket.
So is that like a professional certificate program, or like a selective course integrated into your professional program?
It's well, you have to do some classes, but everybody who's specialized. So after 5 years of work, you can do the specialization. And it's like, yeah, you can do 3 courses and 3 months of working with patients, or you can have 9 months of working with patients in 1 week course, 40 hours, 1 week. Yeah.
Thank you.
Okay, so I think we can definitely talk more about this topic later, but let me end the session first.
Okay.
So thank you so much for coming, and thank you, Dr. Hugo, Dr. Ursula, for this wonderful seminar. Thank you.
Okay.